Hey everyone, good evening, and welcome to this WooU webinar, Diabetes, New Testing and Treatment for Retinopathy and Macular Edema with Dr. Nate Lighthizer. Thank you so much for being here with us. We're super excited and very much looking forward to learning from you. Next slide. So I'm Dr. Elise Kramer. I'm in Miami. And where are you, Dr. Lighthizer?
I'm located in Tahlequah, Oklahoma, is where I practice at the Oklahoma College of Optometry, but currently in Pierre, South Dakota. So in a hotel room, as many of you can probably see.
Awesome. So let's talk a little bit about Dr. Nate Lighthizer. So he was born and raised in Bismarck, North Dakota, and is a graduate of the Pacific University College of Optometry. Upon graduation, he completed a residency in the family practice optometry with an emphasis in ocular disease through Northeastern State University, Oklahoma College of Optometry. Dr. Lighthizer has since joined the faculty at the Oklahoma College of Optometry and serves as the Chief of Specialty Care Clinics and the Chief of Electrodiagnostics Clinic. In 2014, he founded and now heads the dry eye clinic at the College of Optometry. Also in 2014, he was named the Director of Continuing Education, as well as the Assistant Dean for Clinical Care, serves at the Oklahoma College of Optometry. Starting in 2020, he was named the Associate Dean of NSU Oklahoma College of Optometry, and he is a founding member and currently serves as president of the Intrepid Eye Society, which is a group of emerging thought leaders in optometry. He was named a member of PCON 250, a list of the top 250 optometrists in the country who practice progressively, provide innovative patient care, conduct optometric research, or excel in academia and share what they have learned with other optometrists to advance the profession. Dr. Lighthizer lectures nationally and internationally on numerous topics, most notably advanced ophthalmic procedures, electrodiagnostics, and ocular disease. So impressive and so thankful to have you here. So all potential relationships have been mitigated. Sorry, what were you going to say?
I was going to say thank you for that kind introduction.
And now I will hand it over to you. Thank you so much again.
Thank you so much, Dr. Kramer, for that wonderful introduction. I want to thank everybody for being here tonight. I want to thank Dr. Wu and WooU and all the people behind the scenes for making this just another great event. Hopefully this evening, they do a bunch of behind the scene works and it's very, very appreciated. And WooU, again, just the name speaks for itself, just outstanding in terms of how they run an event. And it's just my pleasure to be here on this webinar this evening. So as Dr. Kramer said, Nate Lighthizer, I'm a faculty member at the Oklahoma College of Optometry in Tahlequah, Oklahoma. And tonight we're going to talk on diabetes, kind of new testing and treatment for retinopathy and macular edema. And I always start this lecture, I'm going to challenge you guys tonight, like I challenged myself 4 or 5 years ago, going, am I stale when it comes to diabetes? Am I stale when it comes to diabetic retinopathy? I challenge myself, is there more that I can do than what we traditionally do for patients that have diabetes and diabetic retinopathy? And what is that? It's basically pat them on the back. We put it on autopilot, the education we give to the patient, control your blood pressure, control your blood sugar, and I'll see you back in a year. I'll see you back in 6 months. Is there more that we can do from a testing perspective and from a treatment perspective? Again, I'm going to challenge you guys tonight to think about that. Is there more that you can do diagnostically other than our standard testing, which I'll talk about in just a second? And is there more that we can do from a treatment perspective instead of just patting them on the back, telling them to control their sugars, and we'll see them back in a year? So new testing and new treatment for retinopathy and macular edema. If you've been to my lectures before, you know I like to poll the audience. I'm going to poll the audience for a few questions tonight. Of note, this is not required. I say it again, this is not required. You will still get your CE credits. But if you'd like to participate in the polling, you can open up a browser, open up Safari or Google Chrome, and type in pollev.com/my name, Nate Lighthizer. So POLLEV.com/Nate Lighthizer. That will bring up my Poll Everywhere page. Again, nobody likes to raise their hand in a group of live attendees, or in this case, virtual. We can still poll the audience and see what you guys think in terms of the group answers. This is completely anonymous. Nobody will know what you put. I won't even know what you put, but it's nice to see what the group is thinking. What percent put A versus B versus C versus D versus E. Again, I want to emphasize this is not required. not required. You will still get your CE credits if you do that, but there's the polev.com/my name. I always do an intro question. You take a look at this. Do you see managed patients with diabetes and diabetic retinopathy? Yes, I do, or no, I don't. Again, just a simple intro question. You can see we've already had close to 100 people respond. Again, this is completely anonymous. And once again, this is not required to do this. And you can answer via the chat, the Q&A, the poll, and you can just answer in your head, and you'll be able to see, look at that, 93% of the people that respond to the poll, yes, I manage patients with diabetes and diabetic retinopathy. I'm guessing it's close to a daily basis, if not an hourly basis, depending on where you practice, the practice modality, patient demographics, et cetera, et cetera. So here's our course outline. Again, new testing and new treatment. I'm going to highlight the ERG, electroretinogram. I'm going to very quickly highlight OCT angiography and a new a new color vision test called the Rabin cone contrast test. And then we're going to spend some time on nutritional supplementation for diabetes. We've all been very well versed in nutritional supplementation for what other retinal condition? Macular degeneration, AMD. We've got AREDS and AREDS 2, and we've all been very well versed on the role of nutritional supplementation and how it can help other posterior segment disease. We're going to go through some of the literature on nutritional supplementation in posterior segment disease, but in this case, diabetes and diabetic retinopathy. So let's go through this. What do you think of when you think of ERG? I'm going to start with ERG. You guys remember that room in back at school where there was wires everywhere, right? There was wires everywhere. It was dark back there. You didn't want to go back to that room because you didn't know, what would happen. Would I start to look like this and have wires attached everywhere? This is one of my favorite pictures. We're doing a hair here, and I found this one off the internet. We're reading minds with this as well. My point is electrophysiology. It used to be in the research center. It used to be in an academic setting. It used to be only exclusively maybe in a tertiary care retina referral center. But the technology over the last 10 to 15 years has really evolved and advanced. And ERG technology now looks like this. There are handheld devices. There are laptop devices like this, where you hold a little paddle or you actually hold a handheld device, and you can do flash ERGs very, very quickly on these patients. So when I do this with patients, when I do ERGs, again, handheld, or as you can see right here, I always tell them, this may be a new test for you. Have you ever heard of an EKG before? And I think that's an important analogy because all patients have either had an EKG or they know what an EKG is. It's just amazing. We all know what an EKG is. And I tell them an EKG, you've had one before, what they are. They hooked up electrodes to the chest, and it tells you how's the heart firing, how's the heart functioning, basically how is the heart working. And they're going to pair that with structural tests like echocardiograms, like angiography, and that's going to give you a complete cardiac picture. How is your heart overall doing from structure and function? You guys do structure and function so very, very well for a lot of conditions. Name one of them, glaucoma. We all do glaucoma very well in terms of visual field, looking at function. We check their visual acuity. Obviously, that's looking at function, even though it's not the best functional test, but we do visual field for functional, and we do OCT for structure, and we look at the nerve for structure, and we take pictures to look at the back of the eye. My point is, in glaucoma, we do structure and function so very, very well. I want to encourage you to look at that in diabetes as well. Ask yourself this. When you guys manage patients with diabetes and diabetic retinopathy, obviously you are highly encouraged to do a dilated fundus exam. Dilate the eyes, take a look at the back with your 90, your 78, you do BIO, whatever it is, but you're taking a look at the back of the eye. What is that telling you? Structure or function? When you look at the back of the eye and do a DFE, it is telling you structure. What are the two most common ancillary tests that you guys utilize in patients with diabetes and diabetic retinopathy? Two most common ancillary tests. What are they? And the answer is fundus photos and OCT. I bet those are your two most common ancillary tests in patients with diabetes and diabetic retinopathy. And what do they look at? Structure and structure. So when you think of a DFE, fundus photos, and OCT, you've got structure, structure, structure. We need to add some functional tests like an ERG, like a color vision test that we'll briefly talk about as well. OCT angiography gives us a better picture of the vasculature and how that looks. We'll cover that briefly going forward. So let's talk on the ERG and diabetic retinopathy. Here's my first question. Your patient that comes in tomorrow morning, your first patient, 8 a.m. tomorrow morning, is a diabetic patient that's got mild NPDR, no macular edema. Let's assume no cataract, no ocular surface issues. There's no mediopacities at all. They've just got straight mild NPDR. What is their most likely visual acuity? 20/20, 20/30, 20/40, or 20/50? Again, your first patient tomorrow morning, it's a diabetic. They've been diabetic for, let's say, 12, 13, 14 years, whatever it is. They've got no macular edema. They've got mild NPDR. What's their most likely visual acuity? And I'm guessing we're going to be pretty close to unanimous here. It's 20/20. The point is visual acuity is not a great indicator for overall how your diabetic is functioning. Yes, we're going to check visual acuity. Yes, it's important, but they can have structural issues and even functional issues, and yet visual acuity can remain fairly strong. So it shouldn't be our only indicator. Needs to be part of the exam, but it shouldn't be just visual acuity telling you about function, because it's visual acuity is a very small central point in that retina. They can have pretty good visual acuity, yet a mess going on in the macular region and outside the macula as well. So make sure you do visual acuity, but again, it's not the only indicator that we want to do in regards to function. Diabetes, the stats. Again, I got a lot to cover tonight, so I'm going to go very quickly through the stats. I'll summarize this. Are we going to see more and more diabetes or less and less diabetes and diabetic retinopathy over the course of the next 10 years? And the answer is an obvious more and more and more. We're going to see a ton of this over the course of the next 5, 10, 15, 20 years. And optometry really needs to be at the forefront in managing these patients, guiding them, diagnosing them, and again, sending them to retina if they need it, but holding on to them and educating them well in many of these patients there. The rate of diabetic retinopathy is about 35%. This is a general stat. If your patient asks you tomorrow, "Doc, I was just diagnosed with diabetes. I know it can affect my fingers and my toes. I know it can affect my kidneys. I know it can affect my heart, but I also know it can affect my eyes. How likely am I going to develop this diabetic retinopathy that I read about?" The answer is about 1 out of 3. But we all know this depends on numerous things, like what? Depends on control. What's their sugars? What's their A1C? How long have they had the disease? Answer this for me. Generally speaking, which diabetic are you more concerned about? The 15-year diabetic or the 3-year diabetic? Generally speaking, we're probably more concerned about the 15 to 20-year diabetic, because the longer they've had it, the more likely they are to develop retinopathy. So what's the control? What are the comorbidities? How long have they had it? Is it type 1 or type 2? There's a lot of different factors that determine who am I going to be more concerned about? Who am I going to be less concerned about? And 1 out of 13 patients will develop proliferative. And if they had proliferative retinopathy, they likely had non-proliferative retinopathy before that. Again, is there more that we can do than watch and wait? I'm guilty of that in the past, of just watching and waiting, waiting for structural changes, waiting for hemorrhages, waiting for microaneurysms. Is there more that we can do? Again, I'm going to challenge you guys that through this new testing here. So again, severity of disease. This is a nice table from the American Academy of Ophthalmology, the preferred practice patterns in 2019. And you take a look, and we've got the different stages of diabetic retinopathy. Most often, from an optometric perspective, generally speaking, where are our patients? And I always say the first half of the disease, the no retinopathy, minimal retinopathy, mild retinopathy, moderate retinopathy. By the time patients get to severe non-proliferative and proliferative retinopathy, they're often, not always, but often in the hands of ophthalmology or retina specialists. Again, generally speaking, we're in the first half of the disease. Retina is more in the back half of the disease. So I like this table. It gives you a lot of guidance in terms of when do you see them back. Most often, if I asked you, when are you going to see your next diabetic patient back? I'm guessing most of you would say 12 months. You're going to see them back in 12 months, maybe 6 months, depending on severity of disease. But the follow-up, as you can see in this column, really depends on the stage of the disease. The more advanced, the more likely we're going to see that patient, follow them up, check them again, another opportunity to re-educate, et cetera, et cetera. So again, don't forget our structural test. Again, don't let me be mistaken and convince you that ERG replaces fundus photos, that color vision replaces OCT, that OCT angiography replaces OCT. You still need them. Add up the entire picture. Nice photos when you take a look at the back, because you're not going to remember what this looks like 6 months from now, but a picture is just worth 1,000 words, as we all know, to be able to document exactly what that looked like 6 months ago, 12 months ago. The ERG. This is a flash ERG, and it's a test of overall retinal function because it's a flash of light. And when you shine a flash of light in the eyes, it goes up, down, left, and right. And ERG tells you objectively how's the retina functioning. And again, it doesn't pay attention to small retinal lesions. A flash ERG or full field ERG, a flicker ERG would not be the test of choice to pick up central retinal functional defects. That would be the multifocal ERG, multiple focal spots in the central retina. That's multifocal. The flash ERG, boom, flash of light, diffusely illuminates the retina. It's an overall global test of retina function. How's the retina doing? How's the retina functioning? And it does it from an objective perspective. All they have to do is hold that little paddle or the instrument over their eye, flash, 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 and it gives you objectively how's the retina functioning? And you pair that with your wonderful structural test, fundus photos, OCT, to give you a complete retina picture in patients with diabetes and diabetic retinopathy. Again, visual acuity does a great job of telling you this, the central, 1 to 3 degrees right there. But patients can have issues going on. This was a 53-year-old female that was sent into our clinic, and she was sent in due to her extensive macular changes in both eyes. She was sent in for special testing, OCT angiography, ERG, to figure out what's going on in this 53-year-old female. If she was 83, I would say she's got extensive geographic atrophy. We've got atrophic changes. Fortunately, the central part of the macula hasn't been involved yet. The fovea is not involved yet. Guess what this patient's visual acuity was? 20/20 in both eyes. Why was this patient's visual acuity 20/20 in both eyes? Because the central 1 to 3 degrees, 2 to 3 degrees were not involved yet in this particular patient. Kind of looks like bullseye maculopathy, does it not? Kind of arching around. This patient had never taken Plaquenil, had never taken hydroxychloroquine, chloroquine, or any other contributing medications. Again, that was just a case that drives home the point of that central 2 to 3 degrees. OCT, a phenomenal job in this area, among other areas as well. Multifocal ERG, we're not going to talk about it tonight, but does a great job of saying, how is the central retina? How are these multiple different points functioning? And then the flash ERG overall, from top to bottom, left to right, peripheral, central, everywhere. Overall, how's the retina doing? How's the retina functioning? How's it firing? Again, from peripheral to central and everywhere in between. That is your flash ERG. Again, it is truly a flash of light in this particular case there. So that's your flash ERG. Indications, there's a lot of them. There's dozens and dozens and dozens of indications for flash ERGs. Diabetes and diabetic retinopathy is the number one indication because it's one of the most common retinal conditions that we see. But you could do this in color vision abnormalities. You could do this in visual field abnormalities, unexplained vision loss. If your patient has a suspected, maybe nighttime blindness, I can't see as well at night. There's a lot of different reasons why you would do this. But again, considering what's the functionality of the back of the eye, diabetes, diabetic retinopathy, that's what we're highlighting tonight. When it comes to the full field flash ERG, but do know there's a lot of other things that you can consider. What's the literature say? The role of electrophysiology in the early diagnosis. And I think the key word in the title of this study is early. By the time your patient has a pre-retinal hemorrhage, has a vitreous hemorrhage, has neovascularization of the disc or neovascularization elsewhere, by the time that you see signs like that, the ERG is going to be more useful in terms of therapeutic follow-up, meaning they're getting injections, maybe they're getting laser, whatever it is, and now you're following them from a functional perspective. Are things improving or not? In terms of ERG, in terms of diagnosis, it's most useful early in the course of the disease, before they have cotton wool spots, before they have dot blot hemorrhages, before they have changes, and you can detect functional abnormalities before they have structural changes. In some patients, structure goes before function. In other patients, function goes before structure. It varies. The literature is very clear on that. Sometimes structure goes first, sometimes function goes first. And again, the role of electrophysiology, ERGs, in the early diagnosis of the disease. Most studies show unequivocally that the different types of ERGs detect local abnormalities or widespread pathology, even in very early stages of disease. Assessment of early retinal changes in diabetes using a new ERG protocol, and you can see that right there, and screening for diabetic retinopathy using a new dilation-free full-field flicker ERG recording device. Here's the biggest study that I wanted to cover: enhancing risk assessment. What is our job in your red eye that you see tomorrow? In my opinion, it's to treat that red eye, whether it's uveitis, whether it's conjunctivitis, whether it's keratitis, a corneal ulcer. That patient that comes in with a red eye or an anterior segment condition, an episcleritis, a scleritis, you're going to treat that with topical and or oral medications. What's often our job in posterior segment? It's what is the risk assessment? How likely is this going to go south? How likely do I need to send this to retina? Do I need to send this to ophthalmology? In many cases, we can hold on to, but I want to know the risk. It's going to determine how closely I follow up this patient. It's going to determine what additional testing I will do. So that's our job, is enhancing risk assessment. And this study was released in 2020, and it looked at structure and function. And it followed all of these diabetic patients by doing fundus photos, by doing OCTs, and it added in ERGs for the functional aspect as well. And it said this: okay, if patients were identified, a bunch of these diabetic patients, again, early in the course of the disease, if they had structural abnormalities, how likely did they need intervention in 1 year, 2 year, 3 years? And you can see the stats right there. Okay. Obviously, the longer that the time frame goes, the more likely a diabetic is going to need intervention. What was intervention? It was laser, it was vitrectomy, it was injection, some sort of surgical intervention. How likely were they going to need intervention if they had structural abnormalities? The fundus photos were abnormal, the OCT was abnormal. Over the course of the next 1, 2, 3 years, that's how likely they were going to need intervention. How about if they had structural abnormalities plus the ERG was abnormal? So both took a hit. Now that's how likely they were going to need intervention. And then the third category was, all right, they've got structural abnormalities. They've got hemorrhages. They've got fundus photos abnormalities. They've got OCT abnormalities, but the ERG is still strong. The retina is still firing. It's still functioning well. That's how likely they were going to need intervention. And notice the difference. Your next patient that has structural abnormalities and an abnormal ERG, they are much more likely to need to have a vitrectomy, to have laser, to have injection in the next 1, 2, 3 years compared to the patient that has an abnormal ERG. So looking at structure and function, it helps you identify risk. It helps you to choose the patients. You know what, Mrs. Jones, instead of seeing you in a year, I'm going to see you in 6 months. Instead of seeing you in 6 months, I'm going to see you in 3 months. We're going to do an OCT angiography. We're going to test your color vision. We're going to do a visual field, whatever, fluorescein, whatever it is. But you add up the picture, more testing, follow them more closely, et cetera, et cetera. So ERG has been shown to be a great predictor of ischemia and overall, how is the retina functioning? Okay. Electrodes, again, I don't have time to go through this here, but the electrodes, most often use eyelid electrodes now that look just like that and do very, very nice. So the printout. Very quickly, you take a look at the printout. This is a flash ERG. It's called a fixed luminance, single brightness. And you take a look, and we've got the right eye and the left eye. And this is the qualitative data. This is analogous to the EKG waveform. We all know what an EKG waveform looks like, but I also want numbers. And if you're going to remember one number from this lecture, remember that the strength of most of your ERGs with this ERG system is between about 8 and 22. Somewhere between 8 and 22, the bigger the number, the better. The stronger the retinal response. You do an ERG on most of you, and we're going to get somewhere in the teens. The low to mid to high teens, that's your typical magnitude, the strength of the response for an ERG. Just as important is the consistency, the speed, the repeatability of that response over this 30-second test. Again, this is a 30-second test, non-dilated. They just hold this paddle over their eye, flash, 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 flash for 30 seconds. I want to see a tight wedge in the bottom right quadrant, a tight wedge in the bottom right quadrant. That means it's a consistent, repeatable, fast, strong response. And I always make an analogy, okay? I like to golf, okay? I'm a 30 handicap golfer. So when I go to the golf course, I'm going to hit the tee shot, and the first one, I'm going to stripe it right down the middle. And if I'm a 30 handicap golfer, where's the next tee shot likely going? In the woods to the right or the lake to the left, okay? And that's what happens with an unhealthy retina, a sick retina, an ischemic retina, a dysfunctional retina, is they may have some normal responses in the bottom right quadrant, but a lot of them are scattered everywhere. And you can see the difference between normal on the left and abnormal on the right. Again, there is a normal response. Tight wedge in the bottom right quadrant, tight wedge in the bottom right quadrant. That's what I'll call a healthy golfer. A scratch golfer stripes it down the middle, down the middle, down the middle, down the middle, every single time or most times right down the middle, versus the unhealthy golfer, this unhealthy retina, this retina that's not doing well. It's functioning and firing all over the place. Some of them are good. You can see a couple of them right here, but a lot of them are slower and inconsistent and not repeatable. And notice our range. I want it between 8 and 22. And where is this one? It's falling into the 5s there in terms of our magnitude, our strength of the response. So that is reduced. I do another test called the multiluminance, and you can see this is an area under the line, an area under the curve. I want a nice area under the curve here, long lines moving into the bottom right quadrant. And you can see here on this one, we have no area under the lines. We have no area under the curve, and we have no lines moving into the bottom right quadrant. Again, abnormal ERGs. Encourage you to follow these over time. Just like you do visual fields in your glaucoma patient, looking at the function over time, same thing here as well. How about OCT angiography? Don't forget about OCT-A. We can't see these capillary networks in any of our patients, let alone our diabetic patients, and to be able to visualize, to have a scan that shows you enlargement of the cap of the foveolae vascular zone. So there's normal. Can you take a look at normal here? And I look at this plot a lot down here. I want to see a nice, plush, thick capillary network. What I don't want is capillaries to be dropping out. If capillaries are dying, if capillaries are dropping out, that is a sign of disease, and that is a sign of disease progression. Again, in the past, other than fluorescein, we didn't have a quick imaging tool to be able to image these capillary networks in the macula and around the foveal region. Now we do. Looking for enlargement of that foveolae vascular zone. I want to see a small foveolae vascular zone. As that gets bigger, again, here's normal, nice vessel densities. As that foveolae vascular zone gets bigger and bigger and bigger, those capillaries are dropping out and dropping out and dropping out, and that foveolae vascular zone is getting more irregular and more irregular. So if you have OCT angiography, look at the size of that FAZ, the area of the FAZ. Follow that over time. If it's getting bigger over time, that can be a bad sign. If the FAZ is getting more irregular over time, that can be a bad sign. And obviously looking for, are you seeing capillary dropout? As you can see, we see more and more blue. I would teach our students and residents, I don't want to see a ton of blue on this OCT angiogram. That indicates more and more capillary dropout. And we talked about the FAZ with time as well. Okay, so there's your OCT-A. I'm going to skip through just for time purposes, color vision, because I want to make sure we get to some cases. But don't forget about color vision. We have a cool color vision test called the Raven cone contrast test that combines color vision with contrast sensitivity as well. It's a cool test to be able to isolate the different cones, the reds and the greens and the blues, and it does this through contrast sensitivity. I gotta skip through this for time purposes. There's color vision as a biomarker in diabetes. More and more literature showing abnormalities in color vision in your diabetics before they have structural changes, even in their pre-diabetics, showing abnormalities of those color vision changes as well. So again, that's all I'm going to mention on the color vision with that. Okay, so what do we do about it? We've got this new testing. We've got the ERG and OCT angiography and the Raven cone contrast test or color vision test. What do we do about it? Well, I'd like to think if your doctor did a physical on you, and as part of that physical, they did an EKG, and the EKG came back abnormal. I'd like to think your doctor wouldn't go, whatever. It's fine. We're probably good at this point. You'd be going, no, I just had an abnormal EKG. I bet they'd follow you more closely. They may consider starting you on a medication. They may do additional testing. more education, why this is so important, et cetera, et cetera. When we have patients that have abnormal ERGs, abnormal color vision, the OCT angiography is showing an enlargement of the FAZ, capillary dropout. What are we doing? We're going to change that follow-up schedule. We're going to consider a nutritional supplement. I'm about to talk about nutritional supplementation in diabetes and diabetic retinopathy, but instead of seeing that patient in 12 months, maybe it's 6. Instead of 6 months, maybe it's 3, et cetera, et cetera. Maybe we do other testing, that OCT angiography, that color vision, fluorescein, et cetera, et cetera. Better, more patient education. Have you ever been guilty of putting this on autopilot? Control your blood pressure, control your blood sugar. Mrs. Jones, we're going to add up the entire retinal picture here. I took some photos today. We did some functional tests, color vision, ERG, whatever it was, and we're showing some problems. I'm seeing some things that concern me. And here's why, Mrs. Jones. And I want to follow you a little bit more closely. And this is why we need to watch this, because right now you're seeing pretty well. But diabetes and diabetic retinopathy are a very chronic condition, and I don't want to see this progress to a point where we cannot reverse it down the road. So better and more patient education, maybe more communication with the PCP and early referral or save a referral as well. So I want to talk on nutritional supplementation. Things like the I Promise DVS. And for fair balance, again, mentioning multiple, the Diavis, the science-based health has Diavis. There's Neurontin, there is Ocufolins, there's medical foods. There's a bunch of different of these out there. And I encourage you guys to look at this study, the Diabetes Visual Function Supplement Study. This was a study that was really, really well done. And it was done by Paul Chouse, Stu Richer, and Jeff Gerson. Paul Chouse, the lead author, he practices in Washington. Stu Richer, the late Stu Richer, practiced in Chicago, and Jeff Gerson practices in Kansas City. These are 3 optometrists. And this was published in the British Journal of Ophthalmology. And here's what they did. This was a double-blind, placebo-controlled trial. And it took a bunch of patients that had diabetes with no retinopathy, mild retinopathy, or moderate retinopathy. Sound familiar? No retinopathy, mild retinopathy, or moderate retinopathy. I bet that's most of the diabetics in your practice. Because again, we're in the first half of the disease. You may have some that have proliferative. You're probably co-managing that with retina, but we manage a lot of patients with no retinopathy, mild retinopathy, moderate, maybe getting to severe, but now we're getting close to that threshold of referring out for treatment. These patients had no retinopathy, mild or moderate, and half of them got a placebo. Again, this was a placebo-controlled trial. They basically got nothing. And the other half got the I Promise DVS. And this is a nutritional supplement that contains a wide variety of vitamins, minerals, fish oil, lutein, zeaxanthin, this proprietary blend, things like grapeseed extract, resveratrol. Again, a lot of healthy stuff for the retina, for vasculature. And they took this supplement for 6 months. And in that 6 months, they basically said, okay, we're going to measure all this stuff. We're going to measure contrast sensitivity. We're going to measure macular pigment scores. We're going to measure color vision. We're going to measure the central points on the visual field, neurofibrillary, OCT, lipid levels, A1C, vitamin D3, inflammatory markers, and diabetic peripheral neuropathy scores. We're going to measure a lot of things. Do you think they measured visual acuity in this study? Absolutely they did. What was the visual acuity likely of patients with no retinopathy, mild retinopathy, or moderate retinopathy? You already answered that, didn't you? 20/20. Again, we're going to do visual acuity, but it may not be the best indicator for how your diabetic is functionally or obviously structurally doing. So they looked at a lot of different things: color vision, contrast, macular pigment, visual, the central points on the visual field. Were they more perceptive in detecting those points, and then systemic markers as well? 6-month study. How did the supplement compare versus the placebo? And here's what they found. There's a lot of information on this slide. You can see the various tests, the supplement scores, the placebo scores, and the p-value. And you'll notice that a p-value less than 0.05% is statistically significant. After 6 months of a nutritional supplement, the nutritional supplement group had better color vision scores. They had better contrast sensitivity scores. They had better macular pigment scores. The central points on the visual field, they were more perceptive in picking up the central points on the visual field. Lipid levels got better. Inflammatory markers got better. Diabetic peripheral neuropathy symptom score, how you doing in your fingers and toes, basically got better as well. After 6 months of a supplement, they were functioning better at an ocular level and a systemic level. And this was just 6 months. Imagine 9 months, 12 months, 2 years, 3 years down the road, they got better at this point after 6 months of nutritional supplementation. So to me, this is important data here. If this is something that interests you, send me an email. Paul Chouse is the lead author on this. He is an incredibly knowledgeable when it comes to diabetes. To me, he's the most knowledgeable individual I've ever heard talk about diabetes and diabetic retinopathy. And he typed up it's like a 12-page document about each of these ingredients. It's a paragraph or two on every ingredient in this supplement and why it's healthy for the retina, why it's healthy for the macula, why it's healthy for vasculature. It dives into the weeds, but it's an incredible document, well referenced, like 100 references in this document. Again, it dives into the weeds, but it says, why is vitamin C healthy for the vasculature? Why is vitamin B12? Why is zinc, fish oil? Why is lutein, zeaxanthin, benfotiamine, N-acetylcysteine, things like that? So if you're interested in that, send me an email and I'd be happy to send you that document. Paul's given me that and said I could pass that along to whoever. So 6 months taking a supplement, and they had a lot of measures that were statistically superior. So in 2023, who do I consider recommending DVS formula? Is this for everybody? No. Not every glaucoma drop is for every glaucoma patient. Not every procedure is for every patient. And not every medication or supplement is for every patient. Here's who I consider, excuse me, taking DVS. If they have any degree of structural or functional issues, your next diabetic that's got abnormal fundus photos, abnormal OCT, abnormal OCT-A, abnormal Rabin cone contrast, abnormal ERG, if they have any amount of structural and or functional issues. Remember that study that we covered? How likely are they going to need intervention in the next 1, 2, 3 years if they've got structural issues or functional issues? And if worse, they got both, that's going to be worse. I'm definitely making the recommendation. That's my number one recommendation in 2023. If their vision is down, how many of you have seen a diabetic patient that was 20/25 and you couldn't figure out why? Their vision is down. They have low MPOD tests. If subjectively or objectively they say, I'm just not seeing as well as I used to, I will consider making a recommendation. If they're poorly controlled, their A1C is out of whack, or their sugars are out of whack, I will consider making a recommendation. Or the longer they've had diabetes. We all know the longer they've had diabetes, the more likely they're going to help develop diabetic retinopathy, macular edema, vision issues. Now, of the four, this is the weakest of the four. How many of you have seen a 20-year diabetic that was doing wonderfully? All of you have. They were 2015 sharp. They were well controlled. If your patient that's diabetic, that has been diabetic for 18 years, and they're 2015 sharp, and their A1C is 6.5, you may not need to make a recommendation. So I don't know that it's every patient with diabetes, but these four, and especially these three, structural issues, functional issues, vision is down, poorly controlled, or any combination, we are now making a recommendation of we need to get you on a nutritional supplement that's healthy for the retina, the macula, and vasculature as well. So remember the beneficial effects of nutritional supplements on the development of diabetic retinopathy. Again, you're seeing more and more in this. One other comment. We're just finishing up a study right now, and this DivFus study, told you had a lot of things in this. Double-blind, placebo-controlled. Is it placebo versus supplement? And what did they do better on in all of this stuff? Notice what's not in here, ERG. They didn't do ERG in this test. So basically, we're doing the exact same study right now and studying, does 6 months of this supplement improve abnormal ERGs? We are recruiting 18 subjects. We've got 17 enrolled, 15 of them done. This is one of the subjects from this study. And this was at the bottom was the ERG when we started. You remember that number I gave you between 8 and 22? This was the ERGs, again, outside abnormal limits at the start of the study. And at the end of the study, the magnitudes had nearly doubled in that. So again, we're seeing this in patients, ERGs functioning, getting is better as well. Structure, function with supplementation. So yes, it affects medical decision makings, as we've talked about already. So in my last 15 minutes, I want to make sure I get through 3 or 4 cases here. So this is a 63-year-old female. And this patient was referred in. She was a long-standing diabetic, like she goes, at least 20 years, probably closer to 30 years, I've had diabetes, 63-year-old female. She was sent in because they could not get her better than 20/50 on the referring exam. She was seen in one of our satellite clinics associated with Cherokee Nation here in Northeast Oklahoma, and best corrected to 2040 minus 2050 plus, diabetes, hypertension, hyperlipidemia. Take a look at her medication list, as you can see here. I mean, look at all these meds. We're on statins, we're on Plavix, we're on multiple blood pressure medications, cholesterol meds. We're on diabetic meds, no insulin. So we're on multiple vascular medications, and yet the A1C is 11.0. So maybe that's why we have envisioned down at this point in time. Again, 11.0 A1C, not great control at this point in time. Here's the back of the right eye. I'll give you a couple of seconds to digest this. Back of the right eye. Overall, for a 20 to 30-year diabetic with an A1C of 11, this is actually what? Not bad. This is not terrible. You know, this could be a lot worse. Let me bleach out the nerve. There's nothing on the nerve. Give you a little bit brighter picture. Yes, this is actually an artifact right here. Artifact here, artifact down there. We've got what I called mild retinopathy in the right eye. There did not appear to be any exudates. There did not appear to be any IRMA, any major venous beating, things like that. There's the left eye. Again, there's an artifact here and an artifact there. Again, overall, for a 20 to 30-year diabetic with an A1C of 11, this looks pretty good. Didn't appear to be any macular edema. Again, we've got some microaneurysms, some small little dot and blot hemorrhages, maybe some small cotton wool spots there. There's the OCT. Now take a look at that OCT. If I was to ask you, just based on this slide and this slide, what would you expect her visual acuity was? And I bet most of you would say would be darn close to 20/20. But remember, she was sent in because she's 20/40 minus to 20/50. Vision is down at this point in time. I will show you that her ERGs were abnormal. This is a pattern ERG showing irregular central function. And here's the flash ERG. And you take a look at this flash ERG. And again, we covered these already. Notice, how is this golfer doing compared to in our analogy? This golfer is spraying it all over the lot, aren't they? Numbers that I gave you are between 8 and 22. That's our normal range. With the bigger number, the better. We are at 3.8 in the right eye and 5.4 in the left eye, and scattering everywhere. This retina is not functioning well. A reduced area under the curve, not having long lines moving into the bottom right quadrant. These ERGs are abnormal. So I'd ask you, what are you going to do about this? You know, if you sent this patient to retina, what would retina do with this? Nothing. They're going to watch this. There's no signs of neovascularization. There's no signs of macular edema. The retina would not inject this patient. Retina would not laser this patient. They are going to watch this. Okay. Now we're going to have to educate, well, you know, why is vision down? I actually considered a visual field in this particular patient. And I did a visual field just to figure out, is there something weird neurological going on? The visual field came back, no neurological defects whatsoever. But this ERG is showing this retina is not functioning well, both centrally as well as peripherally. So what did I do in this patient? Well, she meets like every criteria for nutritional supplementation. 20 to 30-year diabetic, uncontrolled. Vision is down objectively and subjectively. Do we have structural issues? Yes. She's got structural changes. She's got diabetic retinopathy. Does she have functional changes as well? The answer is yes, she does. Her ERGs are abnormal, and her Rabin cone contrast test was abnormal as well. Her color vision is down as well. So she met like every criteria. So I strongly recommended we consider nutritional supplementation. She took us up on that offer. Now, here I think is the key point. Is this a magic pill? Is this a magic bullet? She can take this and have 3 donuts for breakfast, and let's have a large Dr. Pepper for lunch, and let's have 4 breadsticks and 5 pieces of thick sliced pizza for dinner. Not going to help at all, is it? This is a portion of a complete protocol. And I talked to her, I said, and I tell her, you are going down a road that you and I don't want you on right now. And at this point, I think that we can throw this in reverse and back away from that edge of the cliff that your vision is barreling towards right now. but you're going down that road very quickly. And I fear what your vision is going to be like a year, 2 years, 3. You've noticed your vision going down over the course of the last year. And yet you have minimal structural issues. You have some structural issues, but the OCT still looks good at this point in time. We need to get a hold of this. And to her credit, she started exercising a little bit. She controlled her diet. She lowered her A1C from 11 into the 8s. She took the nutritional supplement, and over the course of 6 months, her ERG went from that on the left to that on the right. Now, it's not normal yet, but it's moving in the right direction. It's improving. It's showing a stronger response, which is certainly positive. And it's hopeful in this patient as she continues to show improvement for this patient there. Her visual acuity went from 20/50 to 20/10. Totally kidding. I'm totally joking on that. I piqued your interest on there, didn't I? No, she went from 20/50 to 20/30 minus. So visual acuity improved by 1.5 lines or so. A1C is moving in the right direction. She's exercising a little. She's taking the supplement. ERG is moving in the right direction as well. So remember the role of that testing and supplementation in your patients with diabetes and diabetic retinopathy. Okay, I've got 8 minutes left before questions. I'm going to go very quickly through 3 cases, and I'm going to tie these 3 cases together. So case 2, 3, and 4, stay with me for the last 8 minutes here, cases 2, 3, and 4. So this is a 54-year-old Native American female. She's not diabetic. She's pre-diabetic. So we're not diabetic. We're pre-diabetic with a strong family history of diabetes. And you can see, again, pre-diabetic. She's got some other conditions, other issues going on. I've put the med list here. Again, we're pre-diabetic. But she sent in because my vision is down, blurred vision, sent in for OCT testing, maybe some ERG testing to figure out why subjectively, she says, my vision is just down in that left eye just a little bit. She's already had cataract surgery in both eyes, young cataract surgery, clear posterior capsules. There's the back of the right eye. Back of the right eye and back of the left eye. Again, remember this patient is pre-diabetic at this point in time. Pre-diabetic. I'm not seeing any signs of diabetic retinopathy at this point. No microaneurysms, no dot blot hemorrhages, no cotton wool spots, no exudates, no venous beading, no ERMA, etc., etc., etc. OCT. There's the OCT. Pretty good. I think most of us would argue this looks like a pretty close to 20/20 OCT at this point in time. And let's introduce in a case. There's also our OCT, 21-line raster, OCT angiography. And again, I want a nice, healthy, plush, thick capillary network. Again, remember this bottom left one is often what I will look at here. And again, here's your scale. And I want to see a lot in the greens and yellows and oranges and have nice numbers here. And as your capillaries are dropping out and dying, you get into these blues here. The more blue spots, the worse it is. I hope I'm not seeing enlargement of the foveal avascular zone, capillary dropout. And unfortunately, we're seeing some capillary dropout in both eyes there in the right and the left eye. ERG. Again, there's a nice, normal, strong, healthy example. Not this patient, but there's the nice, normal example as we showed you before. Number between 8 and 22, high teens. This is a perfect ERG. Here's this patient. And you take a look and you notice it's not bad in the right eye. Borderline low normal in the right eye. Definitely worse in the left eye. The multiluminance, again, that's what I want it to look like. Nice, normal example. Here's this patient's, again, reduced area under the curve. This is overall showing. Here was my interpretation. We got good, reliable ERGs, low end of normal, borderline right eye, mildly abnormal, definitely in the left eye. I would expect better results in a pre-diabetic showing no structural issues. Vision's down a little bit, okay? ERGs are showing some reduction. With that, communicate to the PCP. I said, you know what? I would expect better results here. She had some other systemic symptoms that made me worrisome here. Sent her for some testing, and her A1C was 8.4. Is she pre-diabetic? Nope, she is diabetic, okay? When would you, if I go back to this, if this was your patient tomorrow, pre-diabetic, just diagnosed with diabetes, when would you see this patient back? And I'm guessing most of us would say, I'd see him back in a year. And that's what I would have said as well. And with ERGs and OCT angiographies that look like this, I would argue a 4 to 6 month follow-up for that initial follow-up would be worthwhile. See the patient again, educate. How you doing? How's the supplement going? Remember why this is so important. We're going to follow you closely. A1C, control that well. We got to get it down from 8.4. So I think you'd see that a little bit sooner. 48-year-old male. Here's case number 3. Annual diabetic exam. No complaints, no concerns. Again, I'm going to compare and contrast case 2, case 3 right here, and case 4, which is next. 48-year-old Caucasian male. No complaints, no concerns. He thinks he's doing well. Type 2 diabetic for the last 16 years. Hey, A1C looks pretty good. 6.6, 2020. Hey, he thinks he's doing pretty well. Visual acuity wise says he's doing pretty well as well. There's the back of the right eye. Back of the right eye and back of the left eye. Back of the right eye, back of the left eye. Again, 16-year diabetic, A1C 6.6. Overall looks pretty darn good at this point in time. OCT at the left eye, and OCT angiography. I'm going to show a slide in just a few slides. Case 2, 3, and 4, looking at OCT angiography in 3 different patients. And again, notice this nice plush capillary network. Right eye, it's a little bit better than the left eye, but both of these much better than case number 2. And guess what? Here's the ERG. And you take a look at this ERG and take a look at this. What did I tell you the normal range was? Between 8 and 22, and he's at 24 in the right eye and nearly 24 in the left eye. This golfer is hitting a 350-yard drive right down the middle. Awesome. In baseball analogies, he knocked this out of the park. Awesome job. Nice area under the quadrant, long lines moving to the bottom right quadrant. So I'm going to ask you, if you take a look at this slide, which patient are you more concerned about? The newly diagnosed diabetic or the pre-diabetic? Or the 16-year diabetic. Again, the newly diagnosed diabetic or the 16-year diabetic. One more time, the newly diagnosed diabetic or the 16-year diabetic. Which one would you see more closely? Which one would you be more likely to order additional testing? Which one would you be more likely to consider nutritional supplementation? Obviously, I'm going to be much more concerned about and follow more closely the newly diagnosed diabetic in case number 2 here. All right, one more case. I got 2 minutes. 77-year-old male, type 2 diabetic, 19 years, A1C 8.2, vision's down in the left eye. Just not great, doc. My vision's just down a little bit. 77-year-old male, A1C elevated. There's the back of the right eye. Back of the right eye and the back of the, you can see a small little MA right here. He had what I called very mild retinopathy in both eyes. OCT here. OCT in the left eye, and OCT angiography. And again, look at that bottom left capillary network down there. Bottom left capillary network in the right eye and the left eye. Let me quickly show it to you. Case number 2, the newly diagnosed diabetic. Case number 3, the 16-year diabetic. And case number 4, the 19-year diabetic. This one kind of falls in between case number 2 and case number 3 there. And guess what? The ERG exactly did the same thing. It fell in between case number 2 and case. This is not as good as the grand slam that case number 3 hit, but it's better ERGs than case number 2. Again, these are low normal. These are not what I would call abnormal at this point. For the most part, the magnitudes look pretty good. Notice we're kind of slowing outside that bottom right quadrant. Again, areas under the curve look pretty good, but we don't have those lines moving into the bottom right quadrant. This retina is not responding as quickly to that flash ERG. So it's not bad, but it's not a great ERG response. This patient also met nearly every criteria. 19-year diabetic, long-standing diabetic, A1C in the 8s. Vision is down, especially in the left eye. ERG is borderline. OCT angiography probably showing some capillary dropout. We recommended nutritional supplementation for this patient. I'm going to skip through this. And this patient, unlike case number 1, remember how that 63-year-old female changed her diet, exercised, got control of her A1C? Is a 77-year-old male likely going to change his diet? What's the answer to that? No. He didn't change his diet. He didn't exercise. I saw him 6 months later. It was about the same. 6 months after that, a year after the first ERGs, and his ERGs are moving in the right direction. Notice the magnitude's improving. The phase is improving. The speed is improving as well. The multiluminance doing much, much better. So remember the role of structure and function. Structure and function in these patients. We do structure so well with fundus photos, OCT. We do our DFE, but pairing it with those functional tests and then considering nutritional supplementation in our diabetic patients helps with diabetic retinopathy, as we saw with the DIVFUS study, and diabetic macular edema. So with that, go right here and let Dr. Kramer take over.